of new faces, lots that I know as well, which is great. Okay. The objectives of today, yes, as John said, we're going to identify and discuss my role as a TNP and Ping's role as a CNS2 Paeds. We'll discuss the basic skills of nasal gastric tubing and urinary catheter placement because the nursing staff won't do this for you with Paeds. You're going to be doing this one for yourself. However, Ping and I will do it for you if you like. Won't be going through the procedure of that because the procedure is the same. It's mainly the tips and tricks of what's different with in a paediatric patient. We'll review some new paediatric equipment that's available and some resources that are available, and then the old guides might get you to complete a service survey for you. Okay, so what's a CNS2? So Ping is a CNS2. So this is an extended nursing role. So she's authorised to do an extended scope in paediatrics. So there will soon be certain medications that Ping will be able to prescribe as standing orders, which currently nursing staff, if they're at that advanced practice level, can and share paracetamol for fever and put on some Henle patches and start a trial fluids. That's it. So we will soon, once our scope is signed off by Tim, we'll be able to initiate a fair whack of medications, and you'll see that a lot of the treatments probably we've already initiated them, and X-rays will soon be ordering as well. So Ping's background, so there's Ping up there. So she has an extensive adult pediatric emergency experience locally and internationally. She has a Masters of Emergency Nursing, SACLS accredited. She was a CNS and CNE here, and has been in the CNS2 role since in paediatrics since January. So we're both really new. It's a new paediatric specialty here. So as we said, extended skills that Ping can do are cannulation, beta puncture, can place IVCs and nasogastric fluid tubes, all plasters, nitrous, which you need to be accredited for, and I'm not sure if medical staff need to be accredited to deliver it as well, or is it just a... Yeah.
No, it's mostly, if you've done anaesthetics, then you can give nitrous, but we don't have any special accreditation process. It's more, if you're an advanced trainee and you're then you have to term.
Cool. That's probably important if you're proceduralist, if you're your assistant. They need to be nitrous accredited. So sometimes we have quite junior nurses down there, so they might just need to get the CNE to come and do the procedure with us. Just think about that in advance. And yeah, as I said, medication, X-ray ordering, waiting and standing order approval. They are written. Okay, has anyone worked with a nurse practitioner before? Most people. Cool, so I'm training to do that, essentially. So there's very, very few nurse practitioners in Australia. In fact, there's only 624 in the whole of Australia, which I found really phenomenal considering there's 331,000 nursing staff. So essentially I'm preparing for that. So I can see, treat and discharge patients currently with the assistance of the Orange consultant that's on. And hopefully over the next few months, once that gets really, we'll be with registrars as well. What I need to do, so they complete the uni course, you need to clock over 3,000, I think it's actually 5,000 advanced practice hours. And then you need to gain endorsement through the Nurses and Midwives Board, and you need to provide a whole bunch of evidence through clinical leadership, education and research. So it'll take quite a while for you to do. In fact, it'll take 3 years in order to clock that many hours. So my background, so I'm acute care Paeds, ED, ICU and NETS. I have a master's, you can read that. And then my extended skills are the same as Ping, however I can suture, glue, foreign body removal, pulled elbow reduction. So if you really want to practice your pulled elbows, let me know at the beginning of the shift, because I'll just reduce them when they come in. So let me know and I'll save them for you. And as I said, see and treat with the consultant. So we cover the week, afternoon shifts. So Ping and I will cover Monday through Sunday afternoon shifts, so we'll be available to you then. I do one non-clinical, that's my shift today, and that's random, that's no set day. and Ping will do a morning shift every now and again. But pretty much we're here in that, peak volume patients, so we are available. So how we can help you is we can initiate treatments. As John said, we can provide guidance and support in patient care and provision of Paeds procedures. And we can tell you where things are and give you the resources. We know what's down there. It can be a little bit confusing when you go down there, so we can point you in the right direction. And how can you help us? So remember that we're here as a resource, and not just for the Paeds area, but also for resus, which is probably where my skill set is stronger. Use our skills when we're available. Teach us. We're very keen to broaden our knowledge of Paeds. And if you could please let me, if you see a patient that you think might be really good for me and it's not busy, I'd love to see them or see them with you. That would be great. Or anything interesting. Okay, so now we crack straight on to procedures. So nasal gastric tubes is probably the hardest thing when you come to a new place is where to find things. So have you walked around the department and have you seen the Paeds section? Cool. So the procedure room, inside the procedure room, there's a couple of trolleys. There's a cannulation trolley. At the bottom of the cannulation trolley, you have your nasogastric tube and catheter drawer. And it's split in half like that. And on the left side, you've got all your nasogastric tubes. Hopefully that's all stocked up and ready to go. Has everyone, just before I go on to the skills, has everyone put a nasogastric tube down the trial? Okay. What about a catheter? Okay. All right. So essentially, the technique is the same. So it's the same technique as for an adult, sterile technique, the catheter, and the same sort of technique with your nasogastric tube. Maybe a measurement's a little bit different. So there's a New South Wales guideline that was just released in January for the placement of nasogastric tubes. And these are really the three things that are different. So we don't use the litmus paper anymore. It's recommended that you use this narrow range pH paper, which I'm not sure the CNC have told me we definitely have it. And you're aiming for a pH of 4 or less. And that's your gold standard of your placement. We don't X-ray children unless they're intubated and sedated and they need it. Do not flush your syringe and then listen in the tummy. That's really recommend against that. And the measurement, it used to be nose to ear to the end of the sternum. Now they're saying, I think it was too high. So now it's like mid-umbilicus. So between the zippy sternum and the umbilicus is your measurement. And we do have a local policy for nasogastric tube placement in children, but it doesn't have these up-to-date things in it. Everything else is the same, but the measurement's different. These two things different. So patient positioning. So I find this is probably the thing that's going to make or break you. If you don't position your patient properly and have a good assistant holding them, then you're going to fail, just like with cannulas. So with a little infant, you can wrap them up like a little burrito. And for an older child, similar position to what you hold them for spaces. So one arm across the chest, one arm on the head. And I'll often get them to put, you can't see lower, but I'll often get the child to put the legs in between mum's legs and then hold them because they will keep you. That's a little fancy way of taping. That's nice. As long as you, it's really good. You really should put the gum feel underneath it because they can mark as pressure area. So that's important. Has everybody used these Catalan wipes before? No? Okay, so these are barrier wipes. So again, these are in the top of the cannulation drawer. These put a barrier down on the skin and make it tacky, so things will stick to it. So they're great. They're great for using this. They're great for cannulas. They're pretty much great for everything where you need to stick something down and make it secure. They're also good for nappy rash, and they create a barrier. So that's just a little tip to use those. And when securing, if you've got a child that's going to pull at it, they're all going to pull at it. curl it up, and then stick it behind their back. And then it's like out of sight, out of mind. You'll find that you'll keep a lot more tubes down if you get it out of their view. Okay, so my hot tips for nasogastric tube insertion are be prepared. So that means get all of your equipment out, ready to go. Have the right size tubes. Does everybody have one of these cards? Okay, I'll pass them around. They're a really good resource. So these tell you all of the all of the normal ranges for children. It also tells you sites, cannulas and catheters, ETT tubes, blah blah blah, for ages. So I'd refer to that before you go and try to shove a 12 down a child's nose or something. In infants, utilise a dummy and some sucrose because they'll swallow it, so that's really, really cool. You can also blow on their face. It's not very OH&S, so you can maybe ask mum to blow on their face, but it startles them and they swallow. So, and that's another good way to get them to take medicine as well. It's a little sharp blow on the face and they swallow. A child, so just like an adult, they can have sips of water and try to swallow the tube down. Really important, obviously, not to push when the child is screaming. We wait for them to take a breath. When they take the breath, they often will swallow at the same time, and then you just slowly push it in between cries. If you feel a resistance, stop, obviously, withdraw 1 to 2 centimetres, and then advance, but slowly twist. And it's the same technique that you can use for catheters as well. So, and you can change the angle of position. Okay, on to catheters. So, yep, same draw, but on the right-hand side.
Can I just pause there for a second?
Yep.
Any questions about any of these?
Thanks.
I think if the child needs fluids, yeah. Do you want to talk to that about, IV versus NGT?
Yeah, sure. So, if a child is mildly or moderately dehydrated and you think you want to replace their fluids, it's recommended that nasogastric is your first point of call rather than IV. Now, that is, and the reasons for that are you can replace your electrolytes better than us giving them through, it's just much more tolerated, it's less invasive, like the whole shebang. When you're giving fluid through a nasal gastric tube, so you know how we give hydrolyte for oral rehydration. When you give nasal gastric rehydration, use gastrolyte. Do you know why?
It's not as tolerable, but it's a better physiological condition. But they won't drink it because it tastes really bad.
Yeah, it's really salty. So, and that's exactly right. So we use hydrolyte because it's more palatable, but it's only got 45 millimoles of sodium, whereas gastrolyte has 60. So preferentially, we should be drinking the gastrolyte as well, but this way drinking is really bad. So that's what we would do. And then if you want to give, if they're mildly to moderately dehydrated and you'd like to give rapid rehydration, do you know what rapid rehydration means? How many mils do you give per kilo and for how long? So 10 mils per kilo for 4 hours. Yeah, great. So it's the same volume of fluid whether you're doing it nasogastric or IV. Obviously just using the gastrolyte is a better osmolarity to it. Cool.
So just one question, sorry. Most of the situation where we're deciding that they've failed their trial fluid, and they are invariably going to actually be admitted for rehydration.
Yeah.
The requirement in other hospitals is they get bloods because the admitting team wants to know how dehydrated they are, how bad the vomiting is being, other hypokalemia. Mm-hmm. So we're going to be enforcing a very unpleasant procedure on them anyway. Yeah. Is there no point then doing a secondary unpleasant procedure on them when we already have a mode of access to give them fluid?
So I guess that would I get your point. I think that would really be up to the paediatrician because I know Phil Coote, if we were giving, wouldn't worry about the bloods. So I think that, does everyone agree with that, or what do you think?
Yeah. I think it's quite paediatrician dependent.
Yeah. Yeah.
But certainly someone would be happy with just an NG.
Yeah, and I don't think, I just briefly read the New South Wales guidelines. It's not recommended, but you don't have to. Obviously, if you're giving, you don't need to do blood before nasal gastric rehydration, but obviously before IV, you would. But yeah, this is recommended. Really important thing when you're doing your nasal gastric or any procedure is that you have the right equipment. Now, there's a whole array of nasal gastric tubes. Well, there's not a whole array. There's size 6, size 10, and size 6, 8, and 10. And there's 2 different sizes. There's 2 different types. There's a PVC and then there's like the silicone. So I'll just send those around. Much, much easier to do the procedure with the PVC one because it's harder and stiffer and you push it down. The silicone one is just quite rubbery and malleable and it'll just fold up in on you. So definitely don't do catheters using this one. You will fail. Make sure you use the harder one. I'll pass them around. And they are in that trolley. And there's a whole bunch of them in the storeroom as well. Now we have a paediatric storeroom. I think that's important for you to know that all the paediatric specific stuff, so whether you're in resus or down in the Paeds area or up on the ward, all of our Paeds equipment goes straight down the end of paediatrics and it's the last door on the left. And it's all very clearly labelled airway, breathing, circulation. So if you run out of those, just go to the storage. It's pretty easy to find. Okay, so urinary catheters now. Who's done a urinary catheter on a child? Just put your hands up. Okay, so that's 50%. So the same sterile procedure as with a adult. The challenges, you don't have a lot of the problems that adults have that they haven't given child, that sort of stuff, that having a large prostate, that sort of thing. But they can be quite hard to see and they can be quite hard to perform. So in little girls, it can be very difficult to identify where the urethra is. They can have cutis labia, ambiguous genitalia and hypostasis, etc. So those are challenges that are already set, and then you've also got the obvious ones such as smaller anatomy, smaller specific equipment, which I'll show you. And a suprapubic aspirate is the preferred method in less than 3 months. Has anyone performed a suprapubic aspirate?
They're easier than catheters or anything.
So that's the preferred method in less than 3 months, or in less than 2 years where it's imperative to confirm a UTA in a symptomatic child and you've had multiple contaminated samples, then you might consider doing it, or should consider doing it as SPA. Really important with urinary catheters that we place in ED, usually are in-out catheters. So we're doing it to get a urine sample. That's like 89% of the ones that we'll do here. To actually put in a Foley's catheter, we do have the appropriate size Foley's. They're in the Roslo and in the storeroom. You're really only doing that in like a resus when you've got an intubated patient that's just a temporising measure before they go. Like it's not in-outs are the ones that you would generally do. So important in that you completely empty their bladder. So don't just take a sample and then, and it's difficult to do because you've got to hold them down for a little bit longer while you completely empty their bladder. The importance of that is it lessens their risk of infection. So the idea is if you've introduced any pathogens when you've gone in, if you completely empty their bladder, then you flush those pathogens out. And it lessens their chance of retention, like with an adult patient. So that's that.
So with I don't know if you've done PICU recently. My understanding is now, even in PICU, they very rarely have urinary urinary catheters. Everyone's on bags to hold urine output. Has anyone done PICU recently? Have they really moved away from these long urinary catheters? even in the ICU setting, or
I don't know. When I was in ICU, they definitely still had them, but that was 5 years ago.
Yeah, because they had my experience, but we had a recent next transfer, and I was thinking that it'd be a good patient to put a urine catheter, and I was informed by one of our guys, I don't know who it was now, but recently doing a picking turn and said very rarely even picking out and then leave them in, I guess, for infection risks and whatnot. But certainly, when I didn't think they had the need, but I was just interested to see if that was, if I was misinformed that was the case. So in the end, we did a pubic. But the reason why you recommend pubic less than 3 months is just technical difficulties. Is that the main reason?
I think it just, well, yeah, I think it increases the risk of everything, but I think that because of the whole set, it's usually you're getting urine sample from a 3-month-old because they have fever, and you're trying to rule out a urinary source, and yes, it's quicker to do an SPA generally, I think, and it's the recommended for like a whole sepsis and blah 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 that you just crack on and do an SPA. Really important before you do any sort of invasive urinary thing is that you do a bladder scan. So easy with your SPA because you're ultrasounding, you can see that there's fluid in the bladder. But nothing's more traumatic or horrible for you to perform try to do a catheter on a child and then get nothing back because you haven't scanned the bladder and it's empty. So that's really, really important to do that. Catheters. Catheter-wise, we've got little female ones, little 6 and 8. And we also have the tubes that you're passing around use the PVC. You will fail if you use the silicone one. It'll just fold in on itself, and then if you're trying to aspirate, then you'll suck the tube in. So using these harder ones, it will work. It will work. These little female ones, you can use them on like neonates, like male neonates, but I wouldn't use them past like 3 months. They're not long enough, and you'll have to go all the way into the field. So that's good. Okay, so my hot tips for urinary catheters. So most of the time, as I said, we're doing in-out catheters because we can't get a urine sample. So there's a few other non-invasive methods that we can use to try and get them to wee. Warm bath, often they'll do a wee. Making sure that they have a really good drink, hopefully if they can drink. And this tapping of the bladder. Has anyone tried just the tapping of the bladder? Did it work?
No.
No? Okay. Does anyone...
says 60% of the time if you rub their lower back and tap on the bladder like 16 hertz and 60% chance.
Yeah. I find the younger they are, the more this works. I think that older kids, they've got a sense of shame, and they don't want you to, like, when they're like 2 or 3, they start to like go, no, what are you doing? And naked and you're tapping on my bladder. But the younger they are, the more this works. So it's recommended. So the idea is give them a drink. You can have their nappy on, that's all cool. Give them a drink, and then 25 minutes later, don't really know why that time, but 25 minutes later, nappy off and just tap it, gently tapping on the bladder. And you can, when they're really little, you can just rub on the sacrum as well. I just asked one of the girls to try that on a little one out there, and it worked. So I suppose it's just patient dependent and how responsive they are to it. Obviously, you want the parent to have some informed consent to explain the procedure to them. It's pretty horrific. So as I said again, a lot of failure often occurs because of improper holding. So with a little baby, or up until like 3 or so, just legs fully out from leg will give you the best chance of success. Never undo a nappy until you have a urine jar in your hand and someone's ready to catch. It's quite often that wee as soon as the nappy comes off. And when you scan, like pre-scanning, just the gel in the tummy, they'll often wee, and cleaning. They'll wee the catheter out. You've probably all experienced that with an adult as well. So just be prepared pretty much all the time with that urinary, with a pot. Yeah, so be prepared and have the right equipment. So the stuff that I've showed you, use that. You should. That's as good as we've got. Make the urethra wink. It'll get them to cough. So we're trying to open up the urethra. There's many little girls. So if you use your catheter, has anyone done this? Just stroke the urethra and got it to just sort of wink at you? No? I seem like a weirdo. So move up your end of your catheter and esogastric tube. You quite often can see the vagina. You see the vagina opening, you know that we're above it. Just gently stroke above that, and often it will just wink at you. You know where you're going to go. Be patient and be gentle, obviously. You don't want to cause too much damage. You can gently push down on the bladder as well, just to move it and to empty it, obviously. For the little babies, please flush them after you put the claw hex on them because it can burn their skin. So just a little bit of water or saline just to flush the antiseptic off them. And again, the same technique. So if you feel some resistance, stop, withdraw, 1 to 2 centimetres, re-advance. If it's a little boy, you can go in between that, change your angle between your 45 and 90 degree. And just get through the opening. So, and a little twist. Really important to scan the bladder before any sort of catheterisation. Okay, so we don't have much left now. We're just going to talk about resources. So, I don't know if you guys, Sarah, have you seen any of the new, the Burns box and the ENT box? That's all right. So, we used to have, all of our Burns equipment and ENT equipment would all be up in the ENT room, which is fine, but often we don't need to use a slit lamp or, visual acuity, and we could just do it all down the back. So, if you need to do a visual acuity or use a slit lamp, you will still need to go up to the adult ENT room, but everything else will be in these boxes for you, hopefully. So at the top so this is in the procedure room. Go in the procedure room directly on the left. Top one's your Burns box. It's got a list of all the dressings and the spray bottle in there. And while I'm on the Burns box, actually, who's called a child with a burn? Yeah, and how did you do it?
Under attack. It was only a limb, so I weren't too worried about temperature and environment.
Yeah, cool. So spray bottle and warm blankets around the rest of them. It's really important. So that's there, spray bottles in there. And then the 2 little boxes below there, your ear, nose and throat. That's got all the little bits and bobs in there, ready to go. Okay, other equipment that we have available. So we do have an iPad. Really, I don't let them have it at the bedside. It's really just a procedural iPad. And because we don't have any way of actually securing it, it just sort of lives in my drawer. So if Thing or I are on, you can ask for it. Otherwise, we've sort of got to lock it away because it will go missing. It's got our Yay logo on it, but I don't think that was something wrong. We have 2 DVD players.
Find my iPads on.
We've got 2 DVD players. Often they're just floating around. We don't seem to have the security with those ones. We do the iPad. So they're really good for, so say you've got a kid that can't see the C-spine, you've got to lay them flat, put them up at 20 degrees, whatever. Really, really difficult to keep them still, as you well know. DVD just sitting next to them. It seems to keep them nice and still sitting on their chest so they can watch it. Okay, hypoglycemic grab packs. So if you've got a kid, what do you bring on you? So sugar less than 2.6. It's recommended that you do a critical sample. Blah blah blah. The reason that the grab packs got made is we had an incident last year where an infant, was continually hypoglycemic, and we didn't have the right tubes, we didn't know the process, We didn't then recognise that he was continually hypoglycemic. So anyway, we've got a grab pack. So the grab pack has a little laminated card in it that has the hypoglycemic flow chart. So what you do and when you do it, and then it's got all of the critical sample bloods that you need to take and labelled, put me on ice, blah, blah, blah. So there's one available on the Broslow trolley, and there's one in the Raft free subs trolley in the second drawer. So often I've given this in service to nearly about, not this in service, but a hypoglycemic one to the majority of the nursing staff, so they should grab that for you. Procedural sunnies, they're not for us to wear, that John thought. So if it's like, so just for the kids to wear with a bright light on them. So they're in the
I thought they were for us to wear. I thought we were going to be